Hello, everyone. This is Dr. Steffen Decker, the orthodontic specialist, for our next straight talk. Today, I have the amazing lady, Dr. Lim, here, who wrote this amazing book, Breathe, Sleep, and Thrive. The first question I have, Lim, is why did you choose this title?
Well, yeah, the book is about promoting healthy breathing for children. It's foundational for them to be able to get their best sleep and to thrive in all aspects of their development. We want them to be able to learn well, to pay attention in class, and, I think that when we can get that right, we can get them to thrive, not just in childhood, but we can get them to grow into adults that can thrive and not suffer with the consequences also.
The question I have is there any personal story of yours which made you come to this topic in the first place? Because I think every one of us has a story why we start questioning what's currently out there, why we explored more into this direction of breathing and health and what impact that has to our children, to ourselves. So what is your story?
Yeah, my story with airway really began with my husband snoring. I think it was about 12 years ago. It was driving me pretty crazy. It was keeping me up at night. So I decided I was going to learn more. I understood that dental appliances could help reduce snoring and, help with that noise in the bedroom. So I just enrolled in a graduate diploma in dental sleep medicine to learn how to be able to help other spouses to not have to suffer with this noise. And so it was through that program, I really learned that actually snoring, can be a sign of more serious problems, and it's associated with increased health risk. And I started to see a lot of patients by referral from sleep physician, recognizing, their quality of life was quite impacted. And yet we're doing this oral appliance, which is really a band-aid for poor jaw development. I really wanted to know, how come we don't grow jaws in the first place? We're taught in dental school you can do early interceptive orthodontics. We can modify children's growth when they're young. But every time we refer to an orthodontist, we get the letter, we're going to do watchful waiting, and we're waiting until children are 12. We're sometimes taking out teeth to straighten their teeth, and we're not addressing the underlying jaw problem. So I think that was a problem for me, and I wanted to help other parents be able to recognize this. And also, I had young children at the time. I didn't want my children to have to go down that path. And so that's really what made me learn more and more about the area and how can we intervene earlier? How can we not just intervene with when jaw development is off track? How can we promote good oral development in the first place? And that comes with getting the mouth to work well during sucking, swallowing, and breathing.
So I get that very frequently that dentists, they're seeing a problem in adults first, then they think, okay, where does it start? I think we need to prevent in children. Then they reach out to a local orthodontist asking for help. Say, listen, you're an orthodontist, you were trained to treat children in growth and development. And at that point, you are getting rejected by orthodontic colleagues of mine who say, we can't do anything right now, we should wait. And what is your personal feeling on this development? Like, I'm very strongly, like I say to orthodontists, what are you guys doing? Why are you not focusing on this huge demand, and why are you not don't care so much about the children to stop this from happening? What is your personal feeling of your experience so far with your colleagues around you?
Yeah, well, when I first came across Dr. Christian Guilleminault's work, really highlighting how palate expansion could help children breathe better, it just made total sense to me. And I approached the orthodontist that we refer to very regularly. Can we do this early interceptive treatment? Do we need to wait? And, really their model of care is we want to do everything efficiently. We don't want to do extended treatment over long periods of time because children are going to burn out. So if we can wait till the jaw development is 90% complete at age 12, the treatment results are going to be more predictable or more efficient. We're not going to have to look after children up for such a long period of time. And so I really, when we can understand that the jaws form our airway and the jaws are growing most rapidly in the first 6 years of life, it just makes sense to modify the jaw development early. And so, yes, it is a little bit frustrating. And that is really why myself as a general dentist, I first became involved in learning how to do early interceptive orthodontics. We need to be able to offer this to more children so that they don't grow up with the consequences of many of the adults that I'm seeing.
And the thing is, I believe it was as hard as it is for you. Like, I'm obviously German trained. I was trained in functional orthodontics from my university already, but with different tools maybe that we have available nowadays. But how was this journey for you of learning how to treat children? Because I believe it's very hard to get this education yourself when nobody is actually performing it. So what did you have to do to get the education to know what you have to do in children? Where do you get it from?
Yeah, so one of the first orthodontists that I learned from is Dr. Derek Mahoney. I'm not sure if you're familiar with him.
Of
Yes, he's
course.
from Australia. So he's in Sydney, and I would have to fly back and forth to Sydney quite often to learn from him, doing his whole course. And I chose him specifically because I knew he's very well renowned for doing early interceptive orthodontics and to help children achieve better faces, non-extraction orthodontics. How can we do things without having to take teeth out? And he's very on board with the connection between airway. So I learned through him. He exposed me to a lot of other different people. The other person that I think was really key was Dr. John Flutter, also in Australia. He does a lot of bioblock expansion, and that's where I learned from. He doesn't teach that in Australia anymore, but
In
yeah,
London now.
so it was really his course. The bulk of what I do is based upon what I learned from him, but doing that comprehensive course with Dr. Derek Mahoney actually just gave me a bigger picture. And I've done a lot of other orthodontic courses, but I think they were the most aligned with the way that I do things now.
So I want to go through a bit in the book. You mentioned about red flags. What are for you the main red flags for parents that they should look out for in their children, which should make them aware there could be something more going on than just the symptoms they currently see? What are the red flags for you?
Like you mean red flags or breathing problems during
Yes.
sleep? Yeah, so I think a lot of parents, they're pretty satisfied if they put their child down to sleep and they don't have to get up for their child during the night. It's like, my child's a really good sleeper. And so a lot of parents don't really recognize what to look for. But for good sleep, we want to see children have their mouth closed, breathing through their nose. They should look pretty still and peaceful, and there should really be no signs of effort or tossing and turning and sweating. So the red flags that could indicate things are off track is when we see children with their mouth open or their lips apart, if there is any sounds or audible breathing or snoring, if there's effortful breathing where you can see them taking a lot of effort to breathe in and out, or gasping, tossing, turning, neck hyperextension or stomach sleeping, teeth grinding, bedwetting, all these signs are unexplained awakenings where we have a child that comes into their parents' room in the middle of the night. We have to question, why are they waking? Is there a breathing disturbance? And when they wake, we want to see them feel quite refreshed on waking. And so they're really the nighttime type of symptoms. And then when sleep is not going well during the daytime, a child is not necessarily going to be sleepy like an adult when they haven't had good restorative sleep. They're going to have more problems of overtiredness or difficulties with their emotional regulation, difficulty sitting still or attention and concentration, maybe sometimes some anxiety. And so there will be changes in their behavior that we need to be alert to, because a lot of the time parents will dismiss things as, normal toddler tantrums or these behavioral things. They get missed. A lot of children may have ADHD-like symptoms when we really haven't investigated the underlying disturbance in
So
sleep.
look, I feel like, obviously for me as an orthodontist, people come predominantly because teeth are not aligned. For you, you're a dentist, the people might come for dental problems. So if you have a consultation in your chair and you suddenly drift into completely different area than your expertise of your face, you talk about ADHD, bedwetting, tongue ties. Sometimes you will, of course, will have patients, parents sitting on the fence saying, hold on a minute, my child is sleeping perfectly, my child is concentrating really well at school, because they think we are attacking them instead of believing us that we want to help them. So how do you overcome this, first of all, this maybe apprehension, because it's so different, the messaging we're getting to these parents? What is it that you do to make them aware that we actually want to help them and create more awareness about this?
Yeah, so when I wrote the book, I believe it took 6 years to write. It's now been out 2 years. So approximately 8 years ago, I was in this boat where I have to try to communicate in a dental appointment. These are the red flags that I'm seeing and how to connect all those dots. So it's a very difficult problem. I really understand that. And that's why I wrote the book. It's not like a simple conversation. Whereas now, you know, people come, they travel and they seek me out for this particular treatment. So it's not that difficult for me anymore. But for instance, we have a new oral health therapist in our practice, and when she is seeing children, I want her to be able to bring up those conversations as well. And so I will get her maybe identify a couple of points, and then she can actually refer people to, whether it be my social media or my website. I try to put out as much information as possible, because I know it's like a lot of things that parents have to take on. So we need to be able to educate them and not expect that they're going to be able to understand everything quickly. But we just need to ask them simple questions like, have you watched your child breathe? Have you noticed whether they snore? And just, you know, bedwetting, teeth grinding, really getting them to start to know what to look for. And I think that's what the book does really well. It just outlines, these are all the things that we need to look at, not just during sleep, during the daytime. What are the red flags when the mouth hasn't worked really well, whether it be breastfeeding problems or speech problems, all these things. And then how to recognize the malocclusions or the crossbites or the high arch palates, and really being able to help parents identify what is the problem when we see these. So yeah, I think it's just about planting little seeds during those regular dental appointments, getting them curious and getting them to look more through these other resources.
Hi everyone, I hope you enjoy our straight talk. If you want to find out more information about the courses we're offering, they're available on our website, theorthodonticspecialist.co.uk, in our course section. And now we will continue with the podcast. Bye!
I see in the background you have a lot of pictures hanging there.
Yes.
Is that part of you show them what it can happen? What is in the background, these pictures?
Yes, it's a poster from the Academy of Orofacial Myofunctional Therapy. I think that's the association, AOMT. And it just lists what are the myofunctional disorders. What are they? What happens when you treat them, or what happens to you when you don't treat them? So I don't really show people, but a lot of the time I have people in here. They may be nursing their baby or spending time post tongue tie release, and they might just have a look at it. And I can just really help them understand these things when the mouth doesn't work well. These are all the things that can happen, you know, whether it be open bite, snoring, chronic neck tension, lisping, all the different things. Why do we need to get the mouth working well? And why is the tongue so critical to function well?
You mentioned a few times now when the parents are nursing their children. So it's about breastfeeding. Quite often I have parents who say to me their tongue tie was released at birth, but they still struggle breastfeeding. So how important is breastfeeding to our children? And when it comes to tongue tie release, what was maybe done wrong that they still didn't get the latch of, and that they then afterwards couldn't breastfeed their child properly? What is it with breastfeeding? Why is it so important to our children to do that?
Yeah, well, one of the most important things that we need for good jaw development or palate development is good tongue suction. So for effective or most efficient transfer of milk from the breast, what needs to happen is that tongue needs to suction lightly to the roof of the mouth. And as it drops, it creates a vacuum, and then that's how milk is effectively transferred. And every time this tongue is raising up and down, breastfeeding is also called nature's palate expander, because that tongue is sculpting that palate nice and broadly. So we're getting optimal palate development when we have good tongue suction with breastfeeding. And also, like, it's a powerful muscle workout, because to get that tongue suctions and extracting that milk well, we also need to get that lower jaw moving backwards and forwards. So it's actually really developing the jaws forward and broadening the palate as well. So it's really helping to expound our airway, because those jaw structures are the outer box for the airway. And so that is why breastfeeding is really important. And if we have, for instance, a tongue tie that doesn't allow proper suction or elevation, then we get other dysfunctions that can occur, and we end up recruiting and using other muscles, and we don't allow the proper development of that tongue. And so how come when we identify a tongue tie and we do a release and feed not be necessarily optimal? Well, when we do a tongue tie release, I liken it to taking a cast off an arm. We can actually help eliminate that anatomical restriction, but it doesn't mean that all of a sudden the arm is going to work well. And it's the same thing with the tongue. And so I do think it's really important that we work in a team approach, because we need to get that tongue working well. And we need to rule out what are the other factors that could be impacting the movement of the tongue, whether there's poor tongue tone or, poor structure, high arch palate, or whether there are other restrictions in the body. So for instance, a lot of babies, if they have any neck or body tension, that can affect their positioning and how wide they can open their mouth and how their tongue can move as well, or their sucking and swallowing reflexes. So I think it's really important to work in collaboration with a lactation consultant that can assess the oral function, how can we optimize it, and work with our body workers who can really identify what other strains and body restrictions that could also be impacting the way that we can move our tongue. And if we don't work collaboratively, we're not as likely to be able to get those good outcomes, because it's a very multifactorial problem.
I think you mentioned a really important topic here is the multifactorial, the team approach, because when you look through the media and the publication newspapers recently as well, that tongue tie release has been tracked through the mud as a business money-making machine. And it is not as easy as just releasing a tongue tie in a baby and everything's going to sort themselves out. It's not black and white. It's the same with airway. It's not just opening a palate and the child will be able to breathe. So I think it's super important that people understand to see a physician like yourself who works in a team of different parties working together for the same goal. I think that's a really, really important message here, and that all, even tongue-tie young children, needs to be assessed by the different parties and not just cut.
Absolutely, because quite often before I even do the release, I want to know that that baby has done some oral exercises or body work and that there are actually improvements. I want my work to be the last piece of the puzzle. It's the most invasive. And so I want to see that they're moving in the direction before we even go. So quite often, the more I do this, the more I realize that there's a lot of the time the tongue tie is not as release urgent as we think that it is. Our lactation consultant is often telling people, do these therapy or exercises for 3-4 weeks for certain babies. And I think the more hidden or more posterior the tongue tie is, the more we really can do to optimize that function before we even proceed.
And when it comes to tongue tie release, do you have different procedures depending on the age of your patient, or do you use always a CO2 laser, or what makes you choose different procedures depending on what patient you see? How do you do it, the tongue tie release?
With the tool, which tool do I choose? Yeah,
Yes.
I'm currently using the light scalpel CO2 laser. So I use it for all ages of release. I think it offers really good precision and really good bleeding control.
So when we talk about sleep, I get a lot of the answer because I ask the parents, the kids, how you're sleeping, and then I get as an answer, oh, my child is sleeping 10 hours a day, but I see very clear signs of sleeping with disorders, tired eyes, dry lips, tongue tie. So I know in my head, I would question this a bit. So when it comes to sleep, Is it the time of sleep which is important, or is it the quality of sleep that is important? And how do we know that the kids get the quality of sleep? What would you say?
I would say that all those red flags that we identified earlier, if we have a mouth-breathing child or a child who is teeth grinding or snoring, they are not going to get their most optimal sleep. So any of those red flags, I would want to investigate that further. I'd want to watch that child more closely. And then someone like ourselves will be able to assess in the mouth what are the risk factors and how can we address each of those risk factors, whether it be a narrow high palate, a low tongue posture.
Do you ask your parents to do a sleep study, or do you ask the parents to take a video recording of their child sleeping, or how would you get the information about their sleep?
Yeah, I would go through with the screening questions with all those red flags. I would really try to prompt them into thinking about what have they noticed, and even their daytime symptoms. What are their daytime symptoms? How is that child functioning? Are they functioning to their best potential? And no, I don't necessarily do a sleep study, because I think sleep studies quite often focus on the more extreme forms of sleep disordered breathing, obstructive sleep apnea, where we need to have prolonged pauses in breathing. However, even a child who has open mouth breathing is going to have, well, we know the research is telling us that they're going to have increased risk of ADHD type symptoms. And we know that even a child who is snoring, who may not have apnea, there's a lot of research linking that to poorer outcomes or increased risk of learning and behavioral problems. So I do think that if a child has any of those symptoms, and there's quite a few to suggest that, and there is a risk factor, I'm quite open to managing that risk factor proactively where I can, because I don't really want to wait for an end-stage problem. If we understand that nasal breathing is important, I want to promote wellness. And what can I do to promote best health?
I totally agree with you, because it's exactly my approach. Like, I think also we have to consider, like, if we get all of these tests done up front, we exhaust already a patient. We sometimes exhaust the financial means of a patient to get something we already know by just looking at the child. So I generally also don't do any sleep studies in children, because the symptoms are very clear to me. And if I can use the compliance and the financial means to actually get going, to start widening the palate, to get myofunctional therapy going in nasal breathing, I think that would help them much more. And the best thing is then when we get the feedback from parents and we see immediately changes in certain behavior, concentration, breathing, that this is the best marketing we can also have as a profession. And so, because I feel sometimes you want all of these diagnostics to be absolutely sure, but that means you need to involve a lot of parties, a lot of financial means, and then sometimes the parents are just exhausted, and there's also a kid attached to it who needs to go through all of these appointments. So I think it's really important that we as clinicians, we prioritize what is the problem and what can we do maybe first to get a better situation. Would you agree to that?
Yeah, absolutely. I mean, there's so much research to support palate expansion as an intervention to improve nasal breathing and even improve sleep outcomes. And I think unless you've seen it happen a few times, it might be hard to be open to that. You may be familiar with the research, and maybe you want to see randomized controlled trials, but there are people that are having real problems where their child, maybe they've already had ENT surgery, their adenoids and tonsils have been removed. Maybe there was a slight reduction in snoring, but there's still ongoing teeth grinding, and that child is still waking up with unrefreshed sleep and having behavioral problems. And it's really difficult for the family to manage. They're walking on eggshells all day. It's creating quite a lot of stress, and I don't think we should leave those patients. And when we do a palate expansion, if they have a narrow palate, very consistently, I see those improvements in the breathing, in the daytime function, and it's a massive relief for patients or parents. And so when you've seen that enough times, it makes sense just to be able to offer that to parents.
So I want to ask you a question, like an ethical question. Who would be responsible? Because there's a recent study who says they compare rapid maxillary expander with watchful waiting. And obviously watchful waiting means we wait till 11, 12, we might outgrow the tonsils like a lot of people say. But who is responsible, in your opinion, for the actually harm that could have been caused by the child just waiting for another 1, 2, 3, 4, 5, 6 years for them to realize actually, I think now it's pretty bad. I think now we need to intercept. So where's the ethical responsibility in that when we just wait for all my colleagues? What would you say to them? Because like for me, you mentioned you see these children early. They have sleep apnea, they have ADHD. Some of them might get bullied. Some of them have night terrors. So there's so many symptoms, and the evidence is only looking at one aspect. They look at expansion and they don't get a breathing improvement. Therefore, it doesn't work. That's the conclusion of the study. So therefore, they say we should rather wait. But for me, the big question is then, if that is your opinion, who's responsible for these X amount of years where kids don't get the help they want, actually, and the harm it could have on them physically, but also emotionally? Because in your book, you also mentioned tooth grinding, tooth wear. So we know that if we are tongue-tied, we have more tooth grinding, which will destroy enamel structure. So then later on in life, we think our young children, diseased dentition, our kids, that they grind is normal. Kids, baby teeth should wear down. So it's all normal. I grind, my kid is grinding, it's all good. I am mouth breathing, my kid is mouth breathing, that's all good. I snore, my kid is snoring, all good. So what would you advise our colleagues to think about the consequence that could have on our children, physically and emotionally? What is your opinion on that?
Yeah, look, firstly, there is some sort of systematic review whether it's worthwhile to watch for weight or treat for children with palate expansion, and how does it impact their obstructive sleep apnea. And there's very limited studies. In fact, in that systematic review, there's only one study that actually compared those patients, and then they found there was no difference. And really, there's not enough research to make a decision either way. But I think when we're talking about obstructive sleep apnea, it really is an end-stage problem. It's not good enough to focus on that. We know that we need to promote nasal breathing. And so some of the research that's looked at adenotonsillectomy, shall we watch for weight or shall we intervene, for instance, with that problem? And they're saying that it's comparable reductions in obstructive sleep apnea. But what they don't show is that when you do the intervention, there's improvements in not necessarily those numbers, but there's improvements in behavior and parent and teacher rated things. So there's other symptoms that we need to be looking at. And to ignore those symptoms and not treat, we're not allowing that child to have their best potential. And we know that there's research to support that children are particularly vulnerable to disturbed breathing and sleep in the earliest years of life. And even when they outgrow these problems, for instance, the Karen Bannock study of 11,000 children, they found that children are particularly vulnerable during the 30-month mark when they have mouth breathing, snoring, or gasping during sleep. That even if they outgrow those problems, by age 4 and 7, it can predict that they're going to have increased risk of behavioral problems. And so children don't necessarily grow out of these problems, the snoring and sleep apnea. They actually grow into this other issue where they have an increased risk of behavioral and learning problems because there is something detrimental happening during that critical window of brain development. And so I think that's really important to recognize. And the other thing that we need to remember is that we need children to breathe well through their nose to optimize facial development. And so if we know that palate expansion can help remodel the airway and improve nasal airflow, from a facial development point of view, to watchfully wait and not promote good jaw development when they're very young, that is not actually ideal for them either. It's a bit detrimental. And so, yes, it will be controversial. There will be people thinking you are just unethical to offer these treatments. But I do think that it is important that we pay attention to nasal breathing.
Hi, I hope you're enjoying our straight talk so far. If you're interested in any mentoring or one-on-one session with me to discuss cases or any questions you might have about the treatments of your patients, please reach out to us in our mentor program. We're offering that. We have more information. It's on our website, theorthodonticspecialist.co.uk. And now we're going back to our podcast. Bye.
Nasal breathing to help a child develop to their full potential from their learning point of view and from their facial development point of view.
I think there are
You're
few
going to get me in trouble, Stefan.
Pardon?
You're going to get me in trouble, Stefan.
Well, look, I think it's really important that we need to be sometimes a bit disruptive to make the minds thinking, because from my point of view, I'm really aware of what's going on out there. So I was trained by John Coyce in Seattle, and John Coyce is a evidence-based education center talking predominantly about adults, restorative, how to restore teeth in the best way. So when it comes to destruction of permanent dentition, we also could ask ourselves, why did they destroy in the first place? So when I asked John this question of basically, could that have been prevented by maybe good early intervention in orthodontics? The answer was probably. So this was for me the time where I started looking into the family side of different age groups, 4, 9, 15, 45, where the genetic gene pool said, okay, we have a deep bite, but we have a very young child with hardly any symptoms. But then more and more destruction on the front teeth happened. And in the adult dentition, we lost already teeth because the health system here decided to solve the crowding by making the foundation smaller. But this is now just tooth related. So now we can talk about area related. I have also adult patients who, a classic example, I had a gentleman in his 40s coming to me for a consultation. And the first question he asked me was, can I record the consultation? Which is already for me a not normal question to ask in a first consultation, because why would he want to ask the coach to record this? So he was a class 3 case, a very dominant lower jaw. And I spotted immediately when he was speaking that he had a lisp and a severe anterior tongue tie. So, of course, as we are experienced clinicians, we ask certain questions immediately. How is your sleep? How is this? We check medical history. So I found out that this gentleman is average sleeping 3 to 4 hours a night. He takes ADHD medication. He takes antidepressants, and he is drinking alcohol very frequently to basically knock himself out at night so that he can fall asleep. And as a consequence, again, as a symptom, he has a very overdeveloped lower jaw, or you can say a very underdeveloped upper jaw. So I was very strict with him. I said, listen, I don't think that I'm right now your main priority, because if you continue the next few years down that pathway of not sleeping and taking all these medications, there's no teeth to align anymore. And that is where it really hit me and said, hold on a minute, this is a gentleman in his 40s only, suffering from all of these mental health problems. And he comes for dominant lower jaw, which is actually underdeveloped upper jaw. So, of course, we could offer him double jaw surgery. But what I do now in children is, even if there's not currently a problem present, and I see, for example, a deep bite, and I see a tongue tie, that I now am at a stage where I can say to parents, because of this and this reason, this might happen to your child the next 10, 20, 30 years down the line. So we might get tooth destruction, we might get sleeping disturbance, we might get concentration issues, that they suddenly start to feel they believe in your story, because at the same time they're self-assessing themselves and checking what is happening with myself, that they think, okay, I understand this, I want to intercept right now so that these problems will never ever happen. And I think we both are now at the stage of our career where we get patients because they come for that reason, because they understand our messaging, we want to prevent. And even there might not be classic symptoms of destruction, of bad health right now in the mouth, but that doesn't mean it cannot develop. And our ideal world is actually that our adults, teens will never have any problems. And you are the same as me. You start very early on at birth with breastfeeding advice and all of these things. So our core intention of being educator, being a clinician, being so passionate about what we do is, you wrote even a book about it with saying everything about it. We want to help to create awareness that if we can intercept as early as whatever age it is, 1, 2, 3, 4, 5, that we should do that, because later on when you see the adults and you see that the ultimate end destruction point of CPAP machines, destroyed tooth structure, diet, gut impact, we have not even scratched the surface with gut health, then we see it could end very dramatically. And I interviewed Mark Levi, Dr. Mark Levi, you know him really well. He has his own personal experience of his adulthood where he had health impact, which made him go to this journey. And I'm really passionate about, we have an obligation at least to educate parents, to give them options and tell them what could eventually happen to their child if not being intercepted right now. Yes, evidence is very vague. Maybe there's no evidence yet. It's to be proven. But our experience says very clearly that we have certain signs we look at, that these red flags we were talking the whole way through, that we should at least mention them in our consultation. So I think it's really important to me. Would you want to add something to that, what I just discussed? Is your own experience similar, or how do you feel about that?
For sure. I mean, you know, in the practice, I deal with a lot of significant problems, and people that have come after seeing, you know, maybe 10 different health professions, they're not getting any answers and they're struggling with their child. So it could be a baby that has had a tongue tie dismissed, and really this baby is screaming the whole time. The parents are just stressed out, very uncomfortable baby, swallowing a lot of air, misdiagnosed tongue tie. Or it could be a family with behavioral problems where their child is struggling, not functioning to their full potential, and it changes the entire family dynamic because of all this difficult behavior. And everything that I see, it's super despairing. But I have to say the most despairing for me is seeing those adults that have actually struggled for years or decades and looking at their jaw structure and going, wow, this is an underlying issue. And it's so much more difficult to treat. We have limited providers. It's just more extensive, the treatment required. And thinking, wow, we could have prevented this, because we do see those people that have had, you know, chronic pain, depression, anxiety, really hard for them to function. And, you know, they're just dragging through the day because they're not getting good quality restorative sleep. And for instance, I might have to release a tongue tie because I can see that it's creating referred pain to their head, and they're getting these chronic headaches, but they don't have the tongue space for me to do it because their jaw hasn't developed well. And I feel that's really the hardest thing for me. Despite every problem that I deal with and the struggles that families go through, is the adults that, like you said, just really what inspire me to make sure that people know these problems are very avoidable, and there are so many opportunities for intervention if we can manage it early, but we just need to create more awareness.
So I'm not sure, do you perform with aligners? Do you do clear aligner treatment?
No, I mean, with my orthodontic treatment at the moment, it's so busy, so I really have to restrict myself to maybe like 4 to 8 years at this point. And so I'm doing
when I go to all these conferences of aligned pride, quite often in a class 2 case, for example, the teeth are being moved backwards to achieve a dental class 1.
Yeah.
So, which is from an airway perspective, actually quite frightening, because we know when we go back with the teeth, the tongue will follow somewhere else, also in our airway. So how do you feel about because obviously I'm not sure how it is in Australia, but companies are pushing into the adult market. They're offering dentists a tool and basically say to them, we have AI technology that can write you a treatment plan. You accept it, and then everything will be fine. And quite often we see that when we have, for example, gaps in teeth, which was caused maybe by a tongue thrust, that these gaps are easily closed on a cartoon without actually considering the underlying problem of the gaps. Why are the gaps? What's happening before? So where do you feel this venture will go with dentists offering orthodontic treatment without considering everything we just talked about?
Yeah, I mean, it's hard for me to comment. I don't do a lot of that, but I know even like with extractions to alleviate dental crowding, you know, really we need to be paying more attention to optimizing facial development in the first place and helping those jaws grow during the earliest years of life. That's about the best comment I can give regarding that.
Okay, I don't want to, because obviously I have my personal opinion about that, but what would you say is the main reason why we get so much crowding nowadays in children? What changed in the skulls maybe that causes the dental crowding and the tongue space restrictions nowadays? What is, in your opinion, the main reason for that?
Yeah, I mean, look, the anthropological studies tell us that dental crowding is related to the shrinking of the human jaws and face. And the biggest shifts have occurred with industrialization, where we are getting more processed foods that don't require as much chewing. So we're not using our facial musculature or our jaw musculature as much. So that's not providing the functional stimulus for their development. We're introducing a lot of bottles rather than breastfeeding. Previously, babies could be breastfed up to 3 years in combination with the introduction of solids. There's a lot of processed purees and baby foods. So overall, our muscles are not used as much. And then we have more pollution and difficulties with allergies that are promoting mouth breathing. And so again, mouth breathing, it's sort of reducing the tone of our facial muscles as well. So it is quite environmental, all related to the way that the muscles are working. In terms of why is there an increasing incidence in tongue tie, I'm not really 100% sure regarding that.
So because like we know in the UK, there used to be funding that midwives at birth, they used to cut the tongue ties. And recently a midwife told me that there's actually no funding anymore, that at birth, the midwife are checking tongue ties. So maybe it's just that people don't release tongue ties early on, like we had in Middle Ages, we had the nail, the cutting the tongue ties. So maybe it could be that it could be breastfeeding in the first place, that people are too busy to take time off work to breastfeed a child. Could be the diet, could be a tongue tie. But also what I want to touch base on is when I have parents and I ask about sleep and about tonsil infections, they also very frequently mention that they struggled hearing, like they couldn't hear properly. They got earwax, they got something inserted in the ears. Where is the link between the ears, the hearing, and the breathing?
Yeah, well, there's definitely a link. So, for instance, a lot of what is the link between hearing and the mouth, for instance? Well, we need to have good swallowing to clear the eustachian tubes. And when we don't clear the eustachian tubes, we're going to get more fluid buildup inside the ears and more infections. And this can lead to conductive hearing loss. So we know that the mouth function and swallowing has a very important role in that ear tube function and even how we hear. And so when we have dysfunctional swallowing, whether it be from tongue ties or we're using dummies, which are going to alter the swallowing, there is a link with ear infections and these type of problems. And that's documented in the literature, not so much with tongue ties, but we know that with pacifier use, there's an increased risk of ear problems. We also know that there's research to support that when we do palate expansion, that can also improve conductive hearing loss as well. And so there's a couple of reasons for that. One of them being when we expand the palate, we improve the support or the tension of the soft palate during swallowing, which is really important to clear the eustachian tubes as well. So I think a lot of it comes down to swallowing, and that can be related to the way the tongue is working as well as the jaw structures.
And how do you check in the children if their swallowing pattern is correct or incorrect? What is something clinically you do to check if the swallowing pattern is correct?
When we correct swallowing, what we'd like to see is we'd like to see the tongue suction to the roof of the mouth. And when we swallow, we should see minimal facial muscle activity. So it should look like all the swallowing action is in the neck or the throat. But if there is a reverse swallow where the tongue is not lifting correctly, what we will see is it will kind of look like this, where we see excessive movement of the facial muscles. And so yeah.
That's a good point, because it's really important. It's an easy test, which I ask everyone to do, is if you hold your lower lip away from the face and you ask kids to swallow, you will see that the tongue, where in a swallowing act, is seeking contact to the lower lip. And then you know that there are these tongue thrusting, because basically the visceral swallowing pattern is over the seventh brain nerve, which is our facial nerve. So all our facial muscles are involved. So if you take the lip away, a lot of these children won't be able to swallow. But it's actually not only the children. We see that very frequently also in adults or in teenagers. And then we know that this has impact on it. And it's also really important from an orthodontic point of view, when we talk about stability of our result, that if that swallowing pattern persists after completion of orthodontic treatment, that most likely we will get a relapse at the minute the retainers are not being worn in the mouth. So I think this is something really important, which we can easily detect when it comes to the posterior tongue tie. I think it's a bit harder for people to know what is anterior tongue tie and the posterior tongue tie. So what you obviously do the palatal suction test, I presume, with all of your patients. And would you say when they can get a palatal suction, but they can't hold the tongue up for very long, what would you then do to these patients? Would you give them myofunctional therapy? Or what is your pathway when it comes to swallowing and palatal suction? When you feel there's some improvement that needs doing, what would you then suggest to your patients?
To improve the swallowing?
Yes.
Improve the swallowing. Well, generally, whether my patient comes in for an early interceptive orthodontic consult, a mouth breathing consult, or a tongue tie consult, my plan is really, number one, to optimize the palate structure, to make sure that we have enough tongue space for the tongue to be working correctly. And then, yes, secondly, myofunctional therapy, retraining them where the tip of the tongue is supposed to work, supposed to sit, and then actually, building their awareness and their tongue control and isolation and tone, and then going from there. I don't specifically work on the swallow, but when the tongue can work better, we're going to get less recruitment of those facial.
Would you refer to your colleague myofunctional and they deal with the swallowing, and you focus on the tongue space? Is that correct? Because that's what I do in my clinic. I don't deal with swallowing or breathing. It's
Yes.
my colleague, and I focus literally on the tongue space. Are you doing similar things?
Yeah, similar. We have my functional therapy in-house, but I also use a lot of things like Mayo Munchie and the Healthy Start habit correctors, because when children can wear them and they get better at keeping them in their mouth with their lips closed, it's actually promoting better swallowing as well, without them having to think about it. So I use them as well.
So at the beginning of our podcast, you mentioned you started all with your husband and sleeping. Do you
Yes.
now still treat adults for sleep apnea? And if yes, what treatment modalities do you offer the adults?
Yeah, because of the busyness of the practice, I have really stopped seeing those adults. I'm very well qualified to offer those gentle sleep appliances, but I think that there are a lot more people that can do them now, and I think that I can have more impact by dealing with children younger. A lot of dental sleep medicine, it's taught to do these repositioning devices for the lower jaw, but really I do think that they are just a band-aid solution. They're not particularly precise. A lot of these adults, they have a narrow palate, reduced tongue space. They're not breathing well through their nose. And so I do think that the future is more precision and giving patients the options, including adult palate expansion. And it's really difficult here because we don't really have anyone that is doing a lot of it or, can offer that, I feel, with great confidence. And so it's hard to encounter patients who are struggling and not to be able to offer them the best solutions. And so I have dropped that part of the practice really to focus on children, because this is where I think we can make the biggest difference.
This is so interesting because I came to this country about 9 years ago, and coming to the UK in London, the market was adults, adults, adults. So about 5 years ago, I went back to my fundamental training to children. And like you yourself, we're so busy that I just don't have space anymore for adults. But obviously, when you treat the children, you have the parents as well. And they are asking you for help because they are struggling already. So I'm also like in the US, like with John Coy's group, there's actually a lot of people now who deal with adult airway. And Dr. Christian Leonhardt, who's one of our teachers in the academy, as well as he does something which we call the dome technique, where we basically need to cut bone structures and place a lot of mini screws in the palate to open the palatal structures. But I do agree that we have to go to much more severe treatment modalities to help these adults. And quite often we need to reverse everything that was done in the childhood where they took teeth out, because if we start opening palates with piezo surgery and mini screws, we need to get teeth back in after. So that is sometimes where in adult treatment we create then a conflict, because the adults will say, hold on a minute, why were these teeth taken out in the first place as a kid if you put me implants back in there after? So I agree, there's not so many people out there that offer adult help, and these devices is just opening the airway. It's the same as forward head posture, but it's super invasive, and some people actually don't have the financial means. I mean, we have to be realistic. The normal health system will not pay that because of evidence and all of these things. But to be able to afford that, it's another story. So not everyone can afford these modalities. So lastly, I want to ask you a question. Where do you see is the future going in this? Do you see that's just a trend of airway, or do you see the future dentistry will have airway as the foundation? Or where do you see is the future going, or where do you want it to go?
Yeah, I think the future is really about promoting health, not just managing and reacting to disease, to recognize that nasal breathing is foundational for good sleep and good health and good development, good facial development, and brain development. So I think we need to help people recognize this and what are the early warning signs. and really promote an integrative approach, because when it comes to nasal breathing, traditionally it's like the ear, nose, and throat specialist can take care of it. But what we really need to recognize is that that maxilla, or the palate, plays a very important structural role in our nasal airway. And so dentists and orthodontists have a really key role in developing this. It's not just about the teeth. We have to recognize that this is the foundation, the healthy breathing. And also our myofunctional therapists can play a very big role, because after we've done structural work, whether it be taking things out with an ENT surgery or remodeling the airway with orthodontic treatment, we've got to get those muscles working better and retrain those proper habits with good lip seal, promoting the nasal breathing, getting that tongue to restore proper tongue to palate seal so that we can get optimal breathing. So I think the future is early intervention and recognizing, promoting nasal breathing as a key pillar of health, as well as how can we integrate all together with different professionals and recognizing all the issues, whether it be bedwetting or ADHD symptoms or difficulties with speech articulation. How do we get all those professionals to recognize or assess whether a child is breathing? Because this could be a root issue. So we're not so reactive with dealing with individual problems.
So lastly, is there anything you would like to ask me as an orthodontist that you always wanted to know? Is there any questions you have to me about this topic or in general?
Orthodontists, it's very polarizing, isn't it? There's a lot of division as to, people are on board or people are quite opposed. What do you think the future is? And can you give us some hope?
Well, I'm really passionate about this. Look, in the UK, the changes in the orthodontic market was dramatically. Like 9 years ago, I came to this country, I needed to offer classic orthodontic approaches in a different way because it was all private from the get-go. I came to this country, I needed to be different. And at that time, it was lingual braces for me. So I offered inside fixed spaces and people came for me. But then with clear aligners more and more dominating the market, the dentist got a lot of nice tools that seemed to be working much better than the earlier days. And so the market became very competitive. Therefore, the price structures dropped massively because everyone wanted to get their treatments done. And the differentiation was literally only the price. So at this point, I realized my fee structure is too high. I'm losing customers to dentists. Even I knew that their educational background was very different. So now when I treat the children, again, I found something that is different, and dentists, they don't know enough about everything we just talked about because it's so complex and it requires so much knowledge and education to connect these links to do a good treatment plan. And as an orthodontist, I'm very clear on this. If we think that we can conquer the adult and teen market, we are wrong, because the dentists are already dominating the adult market because they come to the dentist anyway for restorative work. So they might as well do alignment beforehand. And because then they have the parents in the chair, they will have kids and say, we do your teenage cases as well. But when we as orthodontists who have the knowledge about growth and development, we should at least have it. Otherwise, we can get education by myself or anyone else to get education on how do kids grow. This is such a niche that nobody at the moment pays any attention to. So if there are any orthodontists out there, I really encourage you to go into the area of interceptive orthodontics, because this way we do something very nice because it gives us so much positive feedback. We help children to breathe better, sleep better, and to thrive in their life. And that is a very emotional connection as an orthodontist. And that is why I studied orthodontics in the first place, because I wanted to change lives. And over time, I will be able to tell you that you get the teenagers in your chair because they are the brothers or sisters of these kids. And you will get the parents in your chair as well because they are the adults who come every time with the appointment. So I think it's for us orthodontists a way also to regain the market again and not leaving it to a dentist who might look at the financial benefits of aligning teeth before they restore them. So I hope that with this podcast and many podcasts I will be doing in the future, that orthodontists understand this is for me a very emotional topic because treating children is so much different, so much nicer, so much more rewarding. And it changed my life because 5 years ago, I came home nearly depressed because all the consultation I had in my chair were adult cases who needed surgery because of the destruction that happened to them before, and all the easy cases were treated by dentists. So everything that was left to me was surgery cases. So this is not satisfying as an orthodontist because it is a certain price tag attached to that. And when nowadays everything is social media and a lot of patients come through social media, quite often the patients don't have the financial means to do this intervention with surgery. So that's the next problem. So when you go to children, you can actually change the bone structure. You can get all teeth in, you can create a bigger foundation, you can change consequently behavior, sleep, breathing, concentration, and sometimes you just might get a hug from a kid, or you can get a thank you so much, or you can just get the bright eyes full of life. But this is what we want as orthodontists. And if you touch this and if you are brave enough to go into the area which might not be very well researched yet, but you will not get disappointed. And just by talking to parents and the children, they will tell you how much better they feeling. So for me, the future of orthodontics as an orthodontic specialist is prevention. Go to the age group that at the moment nobody cares about, which is below 11. And thinking about the clear aligner market, clear aligners is nothing new. It's just one of the many tools we have in a toolbox as an orthodontist. For teenage patients, the toolbox of an aligner does make it easier because we have a teenage patient who might not like the idea of aligning teeth, who is not very compliant because they're going through a lot of hormonal changes. So just by giving them an aligner doesn't make them have a better treatment outcome. Because for me, my struggles with teenagers is compliance, because as soon as you get 80-90% of alignment, you lose compliance immediately. But the age group below 11 is the age group we have a huge impact on. We can tell a kid, please wear your aligners, otherwise we might extract baby teeth or whatever we have to do. So I get hardly ever a compliance problem with young children. Hence, I can do my job and change their lives. So for me, I'm still very hopeful that orthodontics will survive, because if orthodontists don't change, they will have a lot of competition going on with dentists, because we cannot stop the development that clear aligners did to our industry. It will not stop, it will increase. It's a lot of money involved in that, but we need to change our approach and focus more on children, because hopefully in 50 years time, there are no teeth extracted anymore. There are no children with breathing difficulties. There are no children struggling at school. So if we can just limit these symptoms to a certain degree, I think we both are very happy. And this is why I want to thank you from the bottom of my heart to take the time today. Anyone who didn't read that book, that's a must for everyone to read as a step in stone into this topic. James Nestor, Breathe, is another nice book. we need to start thinking more holistically in that. We need to start opening our mind, because the future is also we're getting health data on our fingertips. And this health data will also tell us that our sleep gets worse after we might have constricted the palatal space and the tongue space. So I did give up my hope yet. That's why I'm teaching a lot. That's why I do podcasts. That's why I fell in love back with orthodontics, which I lost 5 years ago, because I don't want to be the fireman putting the fire out. I want to make sure there's never fire. So thank you so much for taking the time. We keep on spreading the word, and I hope we stay connected. We meet in one of the congresses. Thank you, Shereen, for taking the time today.
No, I want to thank you, Stefan, for reaching out to me, and for your endorsement of the book and taking the time to do this. I really appreciate having more orthodontic colleagues around different countries, really getting on the same page to be able to encourage their colleagues to look at this differently. I can see your passion super clearly, and really grateful to have you as a colleague. Yeah.
Thank you so much. Have a nice day.
Thank
Take
you,
care.
Stefan. Take
Bye.
care.